Okay, what's up guys? Welcome back to the channel. Today we're going to be doing the practice questions for ears, eyes, nose, and throat questions. So this is a topic that's pretty important. And again, we're going to be going through the questions that I made here, and you can go ahead and pause it, I think, to get the most benefit out of it. Pause it and see if you can answer the questions to yourself, and then we'll show the answers after and continue along like that. So we'll start off here. First question is, what is it called when the eyelids and eyelashes are everted, tilted outward, due to a weakness of the orbicularis oculi muscle? So what is that called? How about when the eyelids and lashes are turned inward, inverted? So this one's actually on the screen, but this is Ectropion and Entropion. So Ectropion is tilted outwards, Entropion, like in, Entropion are tilted inwards. Next one is an important one. What is the difference between dacrocystitis and dacroadenitis? Dacrocystitis and dacroadenitis. And how can we manage dacrocystitis? So again, difference between dacrocystitis and dacroadenitis, and how do we manage dacrocystitis? So dacrocystitis is the lacrimal sac itself, which is that medial area next to the nose. There may be obstruction of the nasal lacrimal duct leading to infection in that area. Dacroadenitis, on the other hand, is the lacrimal gland itself, which is more lateral and superior to the eye, and that's where the tears come across the eye and originate in that lacrimal gland. So dacroadenitis, again, the lacrimal gland itself, lateral. Dacrocystitis, the lacrimal sac, which drains near the nose medially, drains all the tears from the lacrimal gland itself. Warm compresses we can do, massage we can do. So sometimes in newborns or young children, it can have a blockage, and we can just massage it and open that up. If we need antibiotics, we can use them, and if it's refractory, we can do a dacrocystorhinostomy. Dacrocystorhinostomy to completely open up that area to allow those fluids to drain out. Next one is a vignette. A patient with Down syndrome comes in complaining of burning and red eyes. You note scaling and crusting of the eyelid margins and some flaking of the lashes. It appears to be red around the rim of the eye. What is this? So again, patient with Down syndrome, a risk factor. Burning and red eyes, scaling and crusting of the eyelid margin, importantly, with some flaking. What are the two main types of this condition? And what is the mainstay of treatment? So there's two main types, and the mainstay of treatment is what? So this is going to be Blepharitis. It can be infectious blepharitis, and that's Staph aureus most commonly, or seborrheic. Down syndrome is a risk factor, and how do we treat it? Eyelid hygiene is the mainstay. You can do warm compresses, scrubbing as well for that condition, blepharitis. Again, infectious with Staph aureus most commonly, or seborrheic as well. Next patient is a patient with a history of rosacea, coming in complaining of a painful eyelid. You note a red, warm nodule on the upper eyelid. What is this? So again, history of rosacea, painful, not painless, red, warm nodule on the upper eyelid. What is that? What is the most common cause of this condition? What anatomy is involved in these two types of this condition? And what is the treatment? So again, anatomy involved, what is the most common cause? And there's two main types here. So this is going to be a hordeolum, or a sty. The Staph aureus is the most common bug, most common cause, Staph aureus for a hordeolum, or a sty, also called. The externals, the two different types anatomically are external, which can be mole or glands of Zeiss. So external is glands of mole or Zeiss. Internal is the meibomian glands. So again, internal meibomian glands, external glands of mole or Zeiss. You can do warm compresses for this, and most resolve within a few days. But if it doesn't resolve in a few days spontaneously, you can do incision and drainage, if not responding again. So first, warm compresses, start conservatively. But again, if it doesn't resolve in a few days, incision and drainage. And again, this is most commonly caused by Staph aureus. Next one is a patient that has a nodule on their eyelid. They say have been there for a while. So a nodule on their eyelid has been there for a while. It is not painful, and it does not move. Not painful, does not move. You note some mild eyelid swelling and a palpable nodule that is firm and circular. What is this? So most importantly, not painful and does not move. And we'll also do another follow-up question. A patient returns from a trip to the desert and states he has noticed a piece of something in his eye. He returned from a trip to the desert. It is in the nasal and medial portion of his conjunctiva and appears yellow in color. He states that it's not decreased or increased in size, so it's not growing. What is this? So the first one's going to be a chalazion. Again, a chalazion, not painful, which is what a hordeolum or a sty can evolve into long term. Chalazion is that non-painful nodule. And the second one is a pinguecula. Pinguecula. So pinguecula is a risk factor is in the desert or windy or stormy conditions. It's an adaptation of the eye, seemingly, and it's a yellow buildup of calcium and fat on the medial portion of this conjunctiva. And that's, again, yellowish in color and circular. So that's pinguecula. Again, yep, so risk factors is a dry or windy or sunny conditions, nodule composed of fat or calcium, and also it doesn't grow. So growing or not growing is an important distinction to make. They might give you that in the vignette. This one, the pinguecula, does not grow, and that's the same thing for chalazion too. Okay, next one is another patient on the same trip from the desert, comes in with a triangular-shaped lesion on the medial conjunctiva and states that it has been growing. What is this? So two most important things, again, same trip in the desert, those sandy, windy conditions, but it's triangular-shaped and it is growing. What is that? And what's the treatment for this? So that's going to be a pterygium. Pterygium. So a pterygium is due to a risk factor is UV light exposure in harsh climates like wind or dusk, as we said. Growing fibrovascular mass. It's triangular in shape. So pterygium, triangular is how I remember it. And you can observe it or you can remove it if the vision gets started to be affected. So if the vision starts to become affected with this pterygium, then you can remove it because it is growing after all. But otherwise, if it's not bothering them, you don't have to remove it. And again, pterygium growing, more of a triangle shape medially. Next one is a patient that comes into the ER after an MVA and complains of severe eye pain. You note that complete loss of vision in the affected eye and gross deformity with obvious hyphema. You note the eye appears to be pushed back posteriorly in the socket, also called enophthalmos. What is the first step in this condition? What is the first best step? So again, MVA, severe eye pain, gross deformity, you see a hyphema, the eyes pushed posteriorly, they have enophthalmos. What are you going to do first? What might be seen upon fluorescein staining, classically, and how do we treat this? So this is going to be a globe rupture, typically after trauma, obvious gross deformity, enophthalmos, the eyes pushed inwards. This is going to be the Seidel sign. So the Seidel sign is when there's a globe rupture, the streaming from the anterior chamber, the aqueous humor. When you put the fluorescein in the eye, typically that covers the eye in that kind of lightish green color, but there's going to be that streaming out of the anterior chamber if there's a rupture of the globe. So it's going to show that fluid that's not fluorescein. So we're going to see that Seidel sign classically if it's a globe rupture. You may also note a teardrop or an irregularly shaped pupil, importantly. And the first step that we're going to do is a rigid eye shield, an immediate ophthalmology consult. So we want to leave any impaled objects in there as well. So immediate ophtho consult and a rigid eye shield, leaving the impaled object in there. So it's an emergency, obviously. Next one is a patient sustaining an orbital floor blowout fracture. What notable eye manifestations will you see based on this location? So again, orbital floor blowout fracture. What notable eye manifestations will you see based on the location of this fracture? How about the skin and the facial area? And what will be seen on CT? So there's a few important manifestations we should know with this condition. And lastly, how do we educate and manage this? So there's a few things we need to educate the patient on, what to do, what not to do after a condition like this. So the eye will have diplopia with an upward gaze. So if it's a floor blowout fracture, then the inferior rectus muscle will be stuck under the eye, which leads to an inability to look up of that eye. So you think the inferior rectus muscle, that typically helps you look down, but if it's stuck between the bone and the eye, the orbit itself, then it's going to be paralyzed basically. And when they try to look up, that's going to be diplopia because they can look up with the opposite eye, but they can't look up with that eye. So it's going to be paralyzed, that inferior rectus muscle. Even though the superior rectus muscle is working, it still can't pull because the inferior rectus is trapped under there. And also we're going to note orbital emphysema from the air in the maxillary sinus herniating into. So if we break the bone, the orbital bone, the maxillary sinus is right there, and of course there's air inside the sinuses, so we're going to have some orbital emphysema. The facial area will have loss of sensation of the anterior medial cheek due to infraorbital nerve affected right below. So A nerve's obviously going to be affected right below, so we're going to have a loss potentially of sensation around the cheek there in the front. CT will show a teardrop sign as the orbital fat sinks into the sinus below. So the orbital fat surrounding the eye, of course, we just made a hole basically into the maxillary sinus. So on CT, we can actually see that fat start to sink into the sinus area. Surgery is potentially the treatment to repair. And we also want to advise them to use decongestants to decrease the swelling and also decrease the pressure building up in that area. And don't blow the nose or sneeze to build up that pressure. And we potentially could give antibiotics as well. Okay, next question is a 2-year-old is being checked for a routine eye examination. He denies any symptoms. You note that there's an absence of a red reflex on fundoscopy, and you note a white reflex instead. What are you concerned about? So very classic 2-year-old routine eye exam, no red reflex, but you note a white reflex. What is your concern? What is the finding on this exam called? What is that white reflex finding actually called? And what is the prognosis of this condition? So what is the prognosis of this condition? That's going to be retinoblastoma. Retinoblastoma, and that sign, that white reflex, is leukochuria. Leukochuria. The prognosis is great if we treat them promptly with a 95% recovery, but it can be fatal if it is missed. The treatment is chemo, radiation. Obviously, you can't do surgery. Most are diagnosed by age 3. So it's important to diagnose it early. Good prognosis. Again, white reflex abnormally. That's leukochuria, and that's a retinoblastoma. Okay, next one is a 76-year-old patient complains of vision loss. She states it has been getting worse rather quickly over the past 2 to 3 months. She notes loss of central vision and detailed vision. So importantly, central vision and detailed vision. What condition is this specifically? So there's a few options here. Specifically, what is this? Again, getting worse over 2 to 3 months. Central vision loss is getting diminished. What is the classic clinical manifestation when using a specific grid test? What do we call this when we're using that grid test? So that's a clue there. What is the other more common type of this condition that occurs over decades as opposed to 2 to 3 months? And what is the hallmark on fundoscopy of this condition? So this is wet macular degeneration, neovascular or exudative macular degeneration. It progresses quickly over a few months as opposed to the decades of dry macular degeneration with those drusen spots. So she has those classic findings of central vision loss. You can use that Amsler grid. So that grid that they can use is Amsler grid, it's called. And you can see metamorphopsia. Metamorphopsia, that straight lines are appearing bent in the center of the vision. In atrophic or dry macular degeneration, the other subtype, again, like we said, progresses over decades. You're going to see drusen spots. Drusen spots, that's very important to know. And small, round, yellow-white spots in the outer retina, that's what drusen spots are. And that's atrophic or dry macular degeneration. Next one, what is the most common cause of legal blindness and vision loss in older adults? Most common cause of legal blindness and vision loss in older adults. What is the treatment for wet macular degeneration? And how about for dry macular degeneration? So we just kind of went over other clinical manifestations and timelines for wet and dry, but now what's the treatment for each of those? And of course, the most common cause of legal blindness and vision loss in older adults is macular degeneration. For wet, we want to do VEGF inhibitors, so vessel endothelial growth factor inhibitors. So you want to inhibit that neovascularization, inhibit those new growing blood vessels in the back of the eye there. That's with VEGF inhibitors in wet macular degeneration. That medication is called bevacizumab that we can use. It's a VEGF inhibitor, again, for wet macular degeneration. For dry, there's not much we can do. We can use antioxidants like vitamin C and E as well as zinc, which may slow the progression but don't reverse it. And we can also give them an Amsler grid at home to monitor their stability so they don't go out and start driving or something when they notice they're having difficulty with that vision on that particular day. So next one, what is the most common cause of new permanent vision loss in an age group of 20 to 74? So again, most common cause of new permanent vision loss in the age group of 20 to 74. On fundoscopic exam, you know blot and dot hemorrhages, circinate hard exudates, flamed shape hemorrhages, cotton wool spots, and microaneurysms. What is this condition? So these are all classic findings of what condition, and this condition is the same thing as here. That's going to be diabetic retinopathy. So again, diabetic retinopathy, whenever you see that age group 20 to 74, new permanent vision loss, that's diabetic retinopathy. And again, any of these classic signs, you want to be thinking diabetic retinopathy. Again, blot and dot hemorrhages, circinate hard exudates, flamed-shaped hemorrhages, cotton wool spots, and microaneurysms. Again, diabetic retinopathy. How about this other one? AV nicking and narrowing is associated with what? AV nicking and narrowing. What is the most severe form of this condition manifest on fundoscopy? What is the most severe form of this condition manifest on fundoscopy? That's going to be hypertensive retinopathy with that AV nicking and narrowing. So important to know, AV nicking and narrowing for hypertensive retinopathy. Papilloedema with blurring of the optic disc margins, and this is considered an ophthalmologic emergency. So again, papilloedema in hypertensive retinopathy. Next one, a patient notices flashing lights and floaters, importantly, before he felt like a black shade came over his eye from one side that slowly encroached upon his central vision. What is this a classic description of? So again, one more time, flashing lights and floaters, a black shade that came over the eye from one side that slowly encroached upon his central vision from peripheral. What is this a classic description of? What are the two biggest risk factors for this condition? What classic sign would be seen on fundoscopy? What classic sign? And how should we manage this patient? That's going to be retinal detachment. The biggest risk factors are myopia and also a previous cataract surgery. So again, myopia and previous cataract surgery. The classic sign in fundoscopy is going to be the Schaefer's sign. So Schaefer's sign, which is an accumulation of brown vitreous cells that resembles tobacco dust in the anterior chamber. So again, brown vitreous cells resembling tobacco dust is Schaefer's sign. We would also see a tear of the retina flapping in the vitreous humor. So the back of the retina is tore off, and we see it flapping basically inside the eye, inside that vitreous humor. It's an ophthalmologic emergency. We want to keep them supine and keep their head towards the side of the detachment. So we basically don't want to rip it off more. We want to use gravity to kind of allow that to sit back down. So if you ever ripped off something and it's flapping in the water, in order to get it back down to where it was, you'd want to make that side more dependent with gravity. So hopefully it doesn't rip more and kind of keeps it at bay to, again, not rip more. So that's how you manage that retinal detachment immediately. Next one is a neonate on day 3 of life, appears to have purulent discharge from one eye and some eyelid swelling. What is the cause specifically at this age? So again, 3-day-old neonate, purulent discharge from the eye. How about if it was their first day of life? How about if this infant was only 1 day old? Then what would be the most common cause? So it's important to know, based on whatever day they give you, what the cause is going to be. What would this infant have had prophylaxis against this condition? So how could we have prophylaxed against this condition at that day 3? And what is the treatment of this day 3 old anyways, since they've already been sick? So how do we treat them anyways since they've already been sick? So again, prophylaxis for this day 3. How do we treat them? And what if it was day 1? So this is going to be gonococcal conjunctivitis. Gonococcal conjunctivitis, that's classically between days 2 and 5 of life. This is also called ophthalmia neonatorum. First day would be chemical conjunctivitis due to silver nitrate most commonly. So day 1, chemical conjunctivitis. Day 2 through 5, gonococcal conjunctivitis. Prophylaxis with topical erythromycin for gonococcal. So important to know that topical erythromycin, 0.5% ointment, covers gonococcal conjunctivitis. And you treat them once they do have this, if prophylaxis didn't work or they didn't get it, with ceftriaxone. So ceftriaxone is the treatment for gonorrhea anyways, so you'd give them ceftriaxone. What if they were 10 days old? Then what bacteria would you consider? And how do we treat this condition? So if they were 10 days old, what bacteria? And how do we treat this condition? And could we have prophylaxed against this condition is an important thing to know. So no, chlamydia trachomatis conjunctivitis is most commonly from 5 to 20-ish days of life. So again, silver nitrate, chemical conjunctivitis, day 1, day 2 through 5, gonococcal, and beyond day 5, basically, chlamydia. You can't prophylax with erythromycin for chlamydia, but you can treat with erythromycin. So again, prophylaxis with erythromycin ointment is good in days 2 through 5 for gonococcal conjunctivitis, but it doesn't work against chlamydia conjunctivitis. But erythromycin is the treatment for chlamydia conjunctivitis. So you can treat them with that once they do have it, but you can't prophylax them with that. Okay, next one. A young patient that wears contacts for vision has noted a gritty feeling in his eye, as well as blepharospasms. He states that he occasionally falls asleep with the contact lens on. What are you concerned about specifically? So again, contact lens, falls asleep with it, feels a gritty feeling now. What is classically seen on fluorescein staining in this patient? And what do we not want to give for this condition? So what do we not want to give for this condition? What is the first thing we always do on physical exam for eye complaints overall? So that's going to be a corneal abrasion in contact lens wearers is a Pseudomonas risk. So we want to be suspecting Pseudomonas in contact lens wearers. We can give topical ofloxacin or ciprofloxacin. If not contact lens, then we can do erythromycin ointment. Staining will show an ice rink linear abrasion. Again, ice rink linear abrasion, especially if a foreign body is there scraping on the surface of the eye. So it kind of looks like an ice rink after you've been skating. You can see those like very superficial skate marks. That's what it looks like on the surface of the eye. Do not give corticosteroids, importantly. It delays healing and predisposes to infection. Also, don't patch if Pseudomonas is suspected. Visual acuity is the first thing we do on a physical exam of any eye complaint to see if they can actually see first. Next one, name that type of conjunctivitis. So next one is a game, name that type of conjunctivitis. So I'll give you a classic symptom or sign of conjunctivitis, and it's important to be able to name what type that is. So there's 3 different types of conjunctivitis mainly, and we're going to see if we can name them based on the classic signs or symptoms. Often in the vignette, they might just describe it to you and expect you to know, is it one of these 3 or 4 types of conjunctivitis? So based on this, see if you can get it. So which one is classically having marked pruritus? So very itchy eyes. Which one has classically itchy eyes? Which one has classically preauricular lymphadenopathy? Preauricular lymphadenopathy. In which one are the eyes stuck shut in the morning? So in which one are the eyes classically stuck shut in the morning? Which one has chemosis? Which one has punctate staining? Which one is swimming pools, the most common source of an outbreak? I just had a question on that. Which one is purulent discharge? Which one starts unilateral and then progresses bilaterally? Unilateral to bilateral. Which one will have cobblestoning of the mucosa of the inner upper eyelid? Which one is highly contagious from direct contact? And which one can be treated with topical antihistamines like olopatadine or visine, which is phenyramine, nefazoline, or etc., some other stuff like that. So the answers here, marked pruritus, allergic. So allergic is going to be very itchy. Preauricular lymphadenopathy, that's classically viral. So they'll definitely give you one with preauricular lymphadenopathy going from one side of the eye to the other. Eye stuck shut in the morning, bacterial. Chemosis is allergic. That just means conjunctival edema. So that's where we see that cobblestoning as well. So chemosis is also an allergic. Punctate staining is going to be viral. So if you see punctate staining, that's going to be viral. Swimming pool is the most common source of an outbreak, is also viral. Purulent discharge, bacterial of course. And like we said, starting unilateral and progressing to bilateral, it's going to be viral. Cobblestoning of the mucosa of the inner upper eyelid, classically allergic. Highly contagious from direct contact, viral, definitely. Treated with topical antihistamines like olopatadine or visine, again, allergic. Okay, next one, coagulative necrosis of the eye is caused by what? How about liquefactive necrosis of the eye? So these each are caused by a specific thing. So coagulative necrosis, which one are you associating that with? How about liquefactive necrosis of the eye? So alkali is liquefactive. How I remember that is alkali has an L in it, and liquefactive also has an L. So alkali is liquefactive, and again, that's worse than acids. So alkali is worse than acids. And coagulative with a C has acidic. It also has a C in it. So coagulative is acidic. Both you want to irrigate with lactated ringers or normal saline copiously. I just got a question on this too, interestingly. They had a alkali necrosis of the eye, and they said, what do you want to do next? Do you want to wash it out with lactated ringers, or do you want to give an acid in order to counteract that liquefactive necrosis, since it is worse than acids? They said that. And I just picked irrigate, because you'd never want to give an acid on top of an alkali, even though it seems like that would neutralize it. Just irrigate. When shining the light in front of a 2-month-old's eyes, one side appears to be asymmetric with the reflection of the light. So again, shining a light in front of the 2-year-old's eyes, one side appears to be asymmetric with the reflection of the light as you observe it bouncing off the cornea. What test is this called? What test did you just do? What could lead to a false positive of this test? And are you concerned for this infant right now? So again, a 2-month-old, are you concerned? So this is going to be the Hirschberg corneal light reflex test, importantly. That's the best initial screening. So Hirschberg corneal light reflex test, best initial screening. What would be a false positive? They could have large epicanthal folds. So large epicanthal folds in the medial side covering part of that eye. It might look like, due to that skin there, that the light is shining off center. So that could give you a false positive if you misinterpret it slightly. You're not concerned yet for this infant because they're only 2 months old, and refer at 4 to 6 months if it doesn't reside. And stable ocular alignment doesn't even occur until 2 to 3 months anyways. So again, after 4 to 6 months, you can refer, but they wouldn't be stable until 2 to 3 months anyways. So it's good that you're screening, but doesn't really mean as much yet. Next one is a 1-year-old that appears to have normal vision. But when you cover one eye, you notice an outward lateral gaze of that eye only when it was covered, and regains alignment when the cover is taken away. What test did you just do? So again, normal vision, but when you cover one eye, you notice an outward lateral gaze of that eye only when it was covered, and regains alignment when the cover is taken away from that eye. What test did you just do? What does this kid also have? A tropia or aphoria? And is an ESO, tropia, aphoria, or exo? So this was the cover-uncover test. And they also have an exo, out to the side, phoria, latent strabismus. So phoria is that latent strabismus. So this kid has an exophoria. This is because the eyes point outward, obviously exo, not ESO is inward, and it's a phoria, not a tropia, because phoria is latent and only presents when you cover the eye. The eye gets lazy, but it snaps back when you do uncover it. Atropia would be more obvious in any test, and when you cover the non-affected eye, the bad eye realigns straight. It's just an overtly lazy eye that needs patch training to train the muscles again. So again, phoria is that latent strabismus only when you do that cover-uncover test. For that latent strabismus is aphoria, and the overt strabismus is atropia, in which you can see that, and you want to cover the opposite eye to train those muscles of that lazy eye, if you will, back again. Next one is a 10-year-old that comes in with pain on eye movement, a seeming bulge on the eye, and the inability to move it when asked. What is this? So classic signs, 10-year-old, pain on eye movement, a seeming bulging of the eye, proptosis, and inability to move the eye, so ophthalmoplegia. What is this? These are classic signs. What is this most commonly secondary to? What is the best test for this diagnosis? How should we treat this condition? And how do we differentiate it from its less serious counterpart based on symptoms? So it's important to know the symptoms they're going to give you, and you have to know, is this more serious or is this more benign? How do I treat this? So this is going to be, how I remember it, is POP, P-O-P, proptosis, ophthalmoplegia, and pain with eye movement. So those are the three things in the vignette that we saw. POP, proptosis, ophthalmoplegia, and pain with eye movement. That's septal or orbital cellulitis, much more serious. Infection of the orbital or the fat posterior to the orbital septum. The most common is secondary to ethmoid sinus infection. The best test is going to be a CT, high resolution, to see in that area. We want to admit them and do IV antibiotics. We can do broad spectrum, so we want to cover them for vanc with also ceftriaxone. Preseptal has no POP, no proptosis, ophthalmoplegia, or pain on eye movement, and you can do outpatient management with antibiotics. So again, most commonly secondary to an ethmoid sinus infection. You want to do a CT, and of course, antibiotics for this condition. Next one is a patient with Bell's palsy that has been having ocular pain, photophobia, and vision changes and redness. On exam, you note ciliary or a limbal flush injection and a hazy cornea with a small hypopyon. What is the likely diagnosis? So again, they have Bell's palsy already. You note ciliary injection, a limbal flush, and they're having some also problems with their eye, photophobia, vision changes, and redness. What will also be seen on slit lamp examination of this patient? That's going to be bacterial keratitis or corneal ulceration. It's deeper than an abrasion, and we see increased fluorescein uptake in this patient. Bell's palsy is a risk factor. It's biggest in contact lens wearers, and we want to treat for Pseudomonas with a fluoroquinolone. So again, always concerned about Pseudomonas for those patients with this corneal ulceration or bacterial keratitis. And why is Bell's palsy a risk factor? Because they have palsy of that seventh cranial nerve, which would shut the eyelid. So they're going to have a problem. Their eyelid is just going to be stuck open. So at night, we want to either patch the eye or help them keep that eyelid shut so it's not drying out, predisposing them to ulcerations and abrasions of that eye. So again, Bell's palsy is a risk factor for this. A patient is having reactivation of herpes simplex in the trigeminal ganglion. What is this a result of? So again, reactivation of herpes in the trigeminal ganglion. What is this? What is the classic pattern we see on staining? And what is the treatment for this condition? Again, there's a classic pattern that they might give you that we see on staining. So remember the trigeminal branches in the cotton wisp test to the cornea are the sensory component of the trigeminal nerve. So remember when we do that cotton wisp test, we see if they blink in response to our sensation of that cotton wisp on the cornea itself. That's the sensory branch of the trigeminal nerve. And this is also where the herpes keratitis reactivates. So we know that herpes can reactivate over some time of being dormant. So it reactivates in that trigeminal ganglion. And this forms that dendritic branching on the corneal surface. And we can see that classic dendritic branching on fluorescein staining. And of course, for herpes, acyclovir is the treatment. Next one is a patient with IBD, inflammatory bowel disease, and they also have ankylosing spondylitis, presents with pain of one eye, and states it looks like his pupil has been unduly constricted. So he's coming in with a pupil that looks constricted and he's having pain in that eye. You know, eye redness, limbal flush, and ocular pain on exam. What is this condition? So classically, when would it look unduly constricted? So it's just constricted more than you would think it would be. And they're having these also other systemic diseases as well. And they're having pain in that eye with a limbal flush too. What is classic on slit lamp examination of this patient? And how should we treat it as well? Important to know. So this is going to be uveitis. Uveitis or iritis. It's more common in systemic inflammatory disorders like IBD, ankylosing spondylitis. Inflammatory cells in flare are classic on slit lamp examination. So if you see cells in flare, in quotes, you want to think slit lamp examination for uveitis. Our treatment is going to be corticosteroids, if topical, on the anterior surface. And if it's a posterior uveitis, then you want to be thinking systemic corticosteroids. Next one, what is lens opacification, difficulty with nighttime driving, and most common cause of blindness in the world? So again, three indicators here. Difficulty with nighttime driving, most common cause of blindness in the world, and also lens opacification. What is that? What are the 4 biggest risk factors for this condition? So this is going to be a cataract. How I remember the 4 biggest risk factors are CASD, cast, cataract, cast, C, cigarettes, A, age over 60, S, steroids, and D, diabetes. So again, cigarettes, age, steroids, and diabetes are the risk factors for cataracts. Next one is a patient with a history of hypertension and idiopathic intracranial hypertension, so 2 different types, complains of headache and bilateral eye pain. Bilateral eye pain. They have preserved vision, however. What are you thinking of initially? So 2 types of hypertension, preserved vision, bilateral eye pain, and also a headache. What will be seen on fundoscopy in this patient? And what is the goal of treatment of this patient? So that's going to be papilloedema. Papilloedema. So they have 2 types of hypertension. They're having increased eye pain as well. Blurred cup to disc ratio and optic nerve and disc swelling. So that's classic for papilloedema. Again, blurred cup to disc ratio and optic nerve and disc swelling. The goal, of course, is to decrease the intracranial pressure. We can use acetazolamide for that to decrease the aqueous humor outflow and also decrease CSF production overall. They do have idiopathic intracranial hypertension as well, so that would help too, acetazolamide. And we want to rule out a mass effect with a head CT too. So again, papilloedema. Next one is a 26-year-old female, previously treated for TB and prophylaxed for malaria before a trip to Africa. So 2 risk factors here. She's 26-year-old, just had TB treatment, and also prophylaxed for malaria for a trip to Africa. Complains of a decrease in color vision and eye pain associated with vision loss. She occasionally notes a blind spot in the center of her vision in one eye that she is concerned about. What's the diagnosis? So again, one more time, the most important things: TB treatment, prophylaxis for malaria, decreased color vision, blind spot in the center of her vision. She's a 26-year-old female. What is the most important etiology to associate with this condition above? What 2 medications was she likely treated with that are associated with the condition? What type of pupil will classically be seen on her exam? And what is the treatment? So these are all some pretty good questions. What type of pupil will classically be seen on her exam? So this is going to be multiple sclerosis is the most important etiology of optic neuritis that we want to see. And again, she was a young female, 26 years old, so they typically give you a young female for multiple sclerosis, and also optic neuritis. So it's important to know ethambutol she was treated with for TB. So ethambutol, ithambutol can cause optic neuritis. That's how you can remember that. And also hydroxychloroquine is a risk for the eyes too. And that was her treatment for malaria. What classic pupil sign will you see on her exam? That's going to be the Marcus gun pupil. The Marcus gun pupil is basically defined as during the swinging flashlight test from the unaffected to the affected eye, the pupils appear to dilate due to a problem in the optic nerve conduction. And the treatment overall for this condition is IV methylprednisolone. So a high dose IV methylprednisolone. And again, one more thing about the Marcus gun pupil, it appears to dilate due to the delay in the conduction of the optic nerve from one eye to the other. So it may not actually be dilating, but it just constricts less when you're shining it from shining the light from one eye to the other, from the unaffected to the affected eye. That affected eye, you'd expect it to constrict more in response to the light, but it can't because the optic nerve is affected in transmitting that signal. So therefore, it's going to constrict a little bit or not constrict at all. And that's that Marcus gun pupil. So next one, we'll do one more question. What is the Argyll-Robertson pupil associated with? The Argyll-Robertson pupil. And how do we remember what Argyll-Robertson pupil is? So how do we remember this? What's the mnemonic for that? Argyll-Robertson pupil, it's classically associated with neurosyphilis as the most common cause. Neurosyphilis. And how to remember Argyll-Robertson pupil? ARP is how I remember it. The accommodation reflex is present, ARP, and the pupillary reflex is absent, PRA. So you just go backwards here. Pupillary reflex is absent, accommodation reflex is present. So they might just tell you, patient comes in, he has a present accommodation reflex, but on pupil exam, you find an absent reflex. What is this? You might have a history of neurosyphilis, or you might be thinking Argyll-Robertson pupil. Okay, we'll stop there for this one, and then we'll continue along in video 2 with ENT questions.